go from there.
Okay, my name's Anne. I'm a nurse in the eating disorder service.
So originally, it did say
Gemma,
but she doesn't work Friday, so we had agreed that it was myself and Anne. So I'm Laura Rayner. I'm one of the registered mental health nurses within the eating disorder pathway.
And we've got a student nurse, Alicia, who's just sat behind us.
Hello.
And she's just recently come into the CAMHs service, so she's kind of using this as part of a nurse experience.
Brilliant.
And she helped put this presentation together as well.
That's fantastic. Thank you.
Do you want us to get on with the presentation? I need to remember how we share screen.
Oh, let me make sure that you can share. Here we go. Right. I'm just going to have to shrink my screen down for a second. Yeah, so you should.
Oh yeah, share my screen. There we go. So fantastic. I will put on my, I need to move that along, don't I? Slideshow from the beginning. Can you see that okay?
Yes, that's brilliant. Thank you.
Okay.
So basically what we have been asked to offer today is kind of an overview of the eating disorders that we work with as a CAMHs service, and generally, again, an overview as to what kind of interventions we offer in relation to those specific eating disorders as well.
Fantastic.
So if I apologise if anybody was expecting anything different, but that was the kind of request that was given to us.
No, that's great. We're really happy to have anything. We've never had anyone come to talk about eating disorders, so I think just finding out anything is really useful. So thank you.
Well, we're happy to share as much as we know.
Wonderful. Is there any chance you can afterwards send me the PowerPoint so that I can share that on the group as well?
Yeah, of course.
Yeah.
Oh, wonderful. Thank you.
Okay, so we're going to just do a bit of it. I'm going to do a bit and Anne's going to do a bit. So we're going to interchange so you don't just hear one of our voices through.
Thank you.
Okay, so we'll just talk a little bit about what we plan to talk about today. So we're going to talk about the facts about eating disorders. We're going to talk about the factors that separate a disordered eating from a clinical eating disorder. We're going to talk about the different types of eating disorders that we see in our CAMHs service. How do we get here in terms of our eating disorder pathway within CAMHs? And the referral criteria that we expect when someone refers into our CAMHs eating disorder service, and how we assess the urgency when someone comes through our pathway. We're going to show you how we calculate a healthy weight range for a young person, because that's different from how an adult healthy weight range is calculated. And we're going to talk a little bit about the support and treatment that we offer when an eating disorder diagnosis has been made, and the high risk factors of an eating disorder and the potential for refeeding syndrome, which we often see quite a lot within our service. So we'll just start off with talking about the eating disorder facts. So we know that anorexia primarily occurs in girls and young women, but prevalence is increasing with boys. Most of our caseload really is girls, but we do have the occasional young male that comes through, but mainly our caseload is for girls. We're knowing that there's an increased prevalence in adolescent females between the ages of 15 to 19 that come through our doors here. And we definitely know that particularly with adolescent patients with anorexia, the prognosis is better if they're treated early, getting in there quick and treating the anorexia to reduce the likelihood of it becoming chronic presentation. So the earlier we can get in to treat, the better outcome that will be for them. And we definitely see that from our perspective in our service. Heritability of eating disorders is around 80%. So if a loved one or a parent has had an eating disorder, that will increase the chances of one of our young people also having an eating disorder. So some facts from our BEAT, which is the leading charity for eating disorders in the UK. So their facts are that 3 children per year will die of anorexia. there's at least 1.25 million people in the UK that suffer from an eating disorder, and 25% of those are male. So the onset of an eating disorder, many develop in adolescence. The youngest is recorded as 6, while research reports that cases of women in their 70s can have anorexia. The prognosis, so a third of cases will result in death, a third of cases result in long-term eating problems, and a third will recover, but it can take up to 5 years. So it is a very hard illness to treat, and it does, you know, involve their motivation, doesn't it, to want to get better. Is there anything else, Anne, from that we haven't added?
No, I guess like in relation to facts for parents, it would just be about, I guess, reiterating that an eating disorder is not something that comes and goes very quickly. That the average, I think the average cycle, they say, from kind of start of an eating disorder to maybe recovery can take up to, they normally say 6 years, but I think the evidence now is saying 7 years.
Wow.
So, and I guess one of the difficulties that we face generally is obviously parents want their children to be as well as quickly as possible. And actually the evidence doesn't support that actually it can be a long kind of lasting illness.
Yeah.
Obviously not true for everybody though. Some people can develop eating disorders and come out of them as quickly as they enter, but generally that's not true for all people that we see.
Gosh, that's really interesting. Thank you.
Okay.
So now we're going to talk to you, or Anne's going to talk to you a little bit about what are the differences between that clinical eating disorder and the disordered eating, which I know was a question, Jill, that you had brought to us that some of the people that you sort of see would like to know.
Yeah, and I think it's quite difficult overall to really distinguish between the difference between a clinical eating disorder and kind of what we would call disordered eating. But I guess ultimately it goes down to diagnostic criteria. So a clinical eating disorder, kind of as is written on the screen, it's a feeding and eating disorder which involves kind of problematic eating and different feeding behaviours, and it cannot be explained by another health condition. And equally, normally for an eating disorder, there has to be a high degree of wanting to influence weight and shape. So typically the eating disorders that people are probably very aware of are anorexia nervosa, bulimia nervosa. There's something called OSFED, which is other specified eating disorders, and there's also ARVID as well, which is the avoidant restrictive food intake disorder. We're aware that there's obviously other eating difficulties as well, such as pica, rumination disorder and obesity, but equally along with ARVID, they're not under NICE guidelines at this point of time. So in relation to trying to separate eating disorder clinically from disordered eating, is that there is obviously some overlap. I guess there's a fine line between clinical eating disorder and disordered eating, so to speak. But not everybody with a kind of eating difficulties will actually fill the criteria diagnostically for an eating disorder. So that might be because they are more subclinical. It might well be that they have like milder forms of eating difficulties. Some can be attributed as well. There's a distinction between eating disorder behaviours for weight and shape purposes versus eating disorder behaviours for emotional regulation purposes. So that might be that there is no wish to alter weight at all. Many other mental health conditions kind of highlight changes in appetite as well. So if you look at personality disorder, there is normally some form of eating disturbance within that diagnosis. But equally with the under 18s, they wouldn't actually be diagnosed with that disorder. There's anxiety disorders and depression, which might involve kind of under-eating or overeating as part of the diagnostic criteria for mood changes. You've got emetophobia, which is obviously fear of vomiting, which might result in somebody having a restricted eating pattern and losing weight. And there's also things such as OCD, which can impact on people's eating as well. And potentially that might not then come under a diagnosis of eating disorder, because that might be in the context of the OCD itself. Yeah, and also as well, like low weight in itself and by itself does not necessarily indicate that someone has an eating disorder. Like unfortunately, we sometimes come across people whose child has low weight, but that's because maybe the family cannot afford a lot of food. there might be evidence of neglect, and although that might be disordered eating, that's in the context of more environmental, social kind of factors.
And I think just to add to that, it is a real grey area, isn't it, really? We'll often have someone with emetophobia, and then you think, particularly if they're low in weight, they may have those body image cognitions purely because they are low in weight, and physiologically, you will tend to have those kind of possible eating disorder cognition. So, you know, it's not that, you know, we're willing to kind of continue assessment to work out, is this an eating disorder or not? It's not always clear cut. So that just obviously just sometimes takes us time to work that out, if it's, you know, an eating disorder or not.
But I think equally as well, there's a distinction between what you might say are eating disorder cognitions and the effects of semi-starvation. Like if a child or an adult is not feeding properly, then actually there'll be changes that take place in brain chemistry, such as becoming more inflexible, maybe more rigid, maybe changes in mood such as irritability, anger, anxiety. And they are actually recognized forms of semi-starvation. So you might say they're eating disorder related, but actually that's what happens to the brain when the body gets starved. So in some ways it is quite a tricky distinction overall.
It is. It's really interesting, actually. Just it's so complex. I don't think I had any idea quite how much there was going on within, you know, the different types of eating.
Yeah, and in some ways they do try to simplify them with the diet, with in some ways the updates of like DSM-5 and ICD-10 becoming 11, but equally it's still quite a minefield at times. So
yeah, absolutely.
So the types of eating disorders that we see within the service here at CAMHs are anorexia nervosa, bulimia nervosa, OSFED, binge eating disorder, and the tricky one is ARFID. So that as a service, we do offer assessment, but the treatment is something that's being considered across the city at this point of time by various services, because it's not under the NICE guidelines at the moment, and also the commissioning for it and its treatment is actually kind of under discussion at this point of time. So we can assess, potentially offer somebody the diagnosis of ARFID, but then in relation to accessing ongoing treatment, that's where the grey area tends to be. So I'm just going to go through kind of well, it looks a lot more complex in relation to the overview of anorexia nervosa. So generally, to meet diagnostic criteria according to the ICD-10, which is a classification of mental health problems, to have anorexia, you'd have to be significantly low weight, and that would be in the context of the high age and developmental stage. Weight loss would need to be rapid, so more than 20% of total body weight within 6 months. Children and adolescents may exhibit failure to gain weight or kind of develop as expected. Low body weight is normally accompanied by persistent patterns of behaviour, such as restricting, exercise, vomiting, purging, and so on. And low body weight or shape is central to the person's self-evaluation. So that means that basically people define themselves by what their weight or what they're eating is doing.
And alongside that, we often have young people that doesn't fulfill that criteria as in being that significantly underweight, but they may be a normal weight, but they've lost sheer amount of weight within a short period of time. And that's when so it's really important, the bit around the rapid weight loss, because typically they may look like a normal weight, but their cognitions are strong and they have lost a significant amount of weight. And we're seeing quite a lot of those, aren't we, at the moment? And they, you know, and so they may not meet the diagnosis of anorexia. So we may kind of say atypical anorexia. So, you know, that's, you know, we do see, you know, those that are a healthy weight as well, but have those concerns.
Okay, so the next disorder that we generally treat in CAMHs is bulimia nervosa or BN. So that generally is characterized by frequent episodes of binge eating. So binge eating tends to mean that somebody would eat a large amount of food in a very short period of time and actually feel that they've lost control over that eating. Generally, in relation to binge eating, people will then tend to kind of compensate for the binge eating. So they will use kind of laxatives, they might self-induce vomiting, they might kind of do strenuous exercise. And also as well, they might have quite a stringent period of restriction as well. and that is too deemed to be a compensatory behaviour. Generally, like anorexia nervosa, there would be a strong wish to influence weight and shape. They might have distress about kind of the binge eating. There may be significant impairments to kind of like the family situations in relation to the cost of how much money is spent on binging and so on. And generally, in order to have a diagnosis of bulimia nervosa, you mustn't meet the requirements of a diagnosis for anorexia. So basically, if you've lost a lot of weight or your BMI is low, even if you binge and purge, you probably will be more likely to be anorexia nervosa binge purge subtype than you would if you were to be bulimic. So this is the DSM-5, which kind of covers all the other eating disorders that are not anorexia or bulimia. So this previously was referred to as EDNOS. So the first one is atypical anorexia nervosa. So basically all the criteria are met apart from kind of the weight at the time is within the normal weight range. So that kind of links into what Laura was saying, that somebody could have been above average weight, lost a lot of weight, would fulfill a typical anorexia nervosa diagnosis, but wouldn't meet the full criteria of anorexia nervosa because the weight is in the healthy range. Binge eating might well be they don't meet the specified frequency of episodes of binging. Bulimia nervosa is the same, that they again might not meet the frequency requested for binging and purging. Purging disorder is where people self-induced vomiting to influence the weight and shape, but actually they have no episodes of binge eating. So they might eat very minimally, or they might just eat normal meals. And then after that, they might self-induce vomiting as a means of compensating. Night eating syndrome is not something that I've ever come across, I don't think, in my entire history of working with eating disorders. But this is generally where people kind of eat during the night. Some of the time they're not aware that they're actually doing it. It might well be the only way they know that is in the morning. There's lots of papers on the kitchen and things like that. And people who have night eating syndrome normally tend to be referred to kind of sleep clinics. So binge eating disorder is characterized by recurrent episodes of binge eating, and generally there is no compensatory behaviors followed by that. People with binge eating tend to binge eat as a means of trying to manage their emotional responses. They would often find it very distressing once they've binged. They would normally have such negative emotions like guilt or disgust. There will be no evidence of any compensatory behavior, so people generally just binge, kind of go back onto their normal pattern of eating, and then maybe binge again. And obviously in relation to binge eating, there's significant impairment in relation to physical health. It can affect the family. It can affect kind of occupational standing and educational purposes and so on. So I guess a common thread is a lot of the eating disorders not just have a physical risk, but equally they come with a lot of impairments on many factors of life. So this is the ARFID, which as far as I'm aware has been around for at least 20 years, but is only starting to come into the kind of mainstream kind of over the past couple of years. And that's normally because of the work of Rachel Bryant-Waugh, kind of formerly of Great Ormond Street, and then presently at the Maudsley. So avoidant restrictive food intake disorder is characterized by avoidance or restriction of food intake. So generally that might involve insufficient quantities or varieties of food kind of taken in, may result in significant weight loss. There might be clinically significant nutritional deficiencies, such as kind of like deficits in vitamins, deficits in iron. They might have to depend on oral nutrition, such as kind of like 40 sips or even chewed feeding. And it can actually negatively affect the physical health of the individual. So there might be children who really don't have enough energy in the day because they're not having the appropriate kind of calorie intake. They might also kind of like have extreme fatigue and tiredness because of lack of iron. Equally, ARVID as well can cause a lot of disruption in families. So meal times can be particularly distressing, especially if the child is kind of refusing to eat something. It can also cause a lot of expense that families have to cook different things for children. It can be quite time consuming as well. And so generally, how ARVID kind of is separate to anorexia is in ARVID, the kind of food refusal is based on maybe like lack of interest in food or only wanting to eat certain foods. There is no generally kind of wanting to influence weight and shape.
And often, like, it's lots of sensory difficulties, isn't it? And not liking particular textures of foods and things like that.
Yeah. I was going to ask, how does this kind of overlap with autism? Because obviously a lot of our children are very restrictive in what they eat because of their autism. Is it something that is common within children with autism?
Yeah, I think you do have children who have ARFID, like based on some sensory disturbances, or there might be some history of that they've choked on a particular food, so they might have a fear of eating certain things for fear of repeating the choking. But a lot of who we see generally with ARFID presentations do tend to fall within the kind of autistic spectrum.
Okay.
And so it would be about looking as to kind of what the sensory kind of issues may be. Sometimes it's just a young person really just has no interest in food at all, not because they're wanting to, I don't know, influence their body image at all, but just because it's not something that they're interested in.
Yeah, of course. Okay, thank you.
We often have young people that when we have done these ARFID assessments that, you know, parents will say to us, you know, they'll try something for a week, they'll eat it over and over and over, but then they'll then get bored of it and decide, right, I'm not eating it anymore.
Yes.
Mum has to try and find another option, and then they'll eat that and then do the same pattern. And
so they normally stay within kind of a very narrow range of foods that they would eat. They normally tend to be of kind of what you would call like bland tasting or kind of bland colours. I think beige is kind of a common colour that people tend to go for. And generally some of them, I think a common food that we've noticed is that a lot of young people will tend to eat things like noodles and chicken nuggets, and they tend to be the accepted foods, whereas anything else that may have like colour, like some fruit and vegetables and things like that, is not something that they would generally be choosing to eat.
Sauces are a no-go, aren't they?
How so sorry, because I know this is relevant to a lot of our families. We were just talking about this just before you guys arrived. So how would you go about getting a sort of diagnosis of ARFID if your child sort of got autism? Is there a particular pathway to getting that looked at more closely?
If they are, I mean, generally, if they are under the CAMHs umbrella, then they would normally be referred to us, and that would normally be because there would be significant concern about the child's kind of like physical well-being.
Yeah. So is that the kind of, is that the point, if they're losing weight, is that when it becomes a concern for CAMHs, or is it?
Yeah, potentially so at this point of time. Also as well, it's not just about weight loss. It might be because there's nutritional deficiency as well. So say, for example, if somebody's only eating chicken nuggets, they're probably missing a lot of the wider food groups. And actually that would then cause for concern. It's generally when it comes to a point where there is any potential detriment to the child's kind of like overall physical and emotional well-being.
Okay, that's really useful. Thank you.
When it's really clear that their growth is really
impaired,
so they're not following that same centile that they were born on, and you know they're dropping centiles on height or dropping centiles on weight, and you know that's another indicator that they're, you know, there's something, that there's an impairment there.
Okay.
And I think the research they're looking at, the MAUDSLEY, is they're looking at whether or not there's any overarching connection between kind of ARFID and anorexia, and there generally isn't per se at this point of time. But say, for example, if the kind of restriction of food became something other than lack of interest, or I don't like that particular type of food, and it started to go into weight and shape concerns or body image or fear of fatness or counting calories or whatever it is, that then becomes more of an eating disorder than it would just an ARFID diagnosis.
Okay.
Yeah, and that is becoming quite a bit of a link, isn't it? Like you said, the research is that, and we often do have, you know, we do see young children coming through as presenting with anorexia who have got a diagnosis of autism, or we are seeing those, you know, those girls that they don't necessarily, they're harder to detect, isn't it, with autism? You know, they normally get a late diagnosis, so they're coming in for anorexia, but actually we're thinking there's a potential, you know, autism diagnosis that's been missed, because often with girls it's harder to detect, isn't it?
Yes. Yeah, absolutely.
Okay, so we're next going to kind of move on kind of how do we get here? How do we, you know, how have we got this eating disorder pathway within CAMHs? You know, previously, you know, the eating disorders service didn't exist. We had patients with anorexia, but it fell within our sort of CAMHs team, and you know, the people that had that experience and expertise in eating disorders would kind of pick up those cases. But in 2014, the government made a pledge and gave a lot of money to children's mental health to think about putting a lot of changing the way the services worked with eating disorders, and improving access to early intervention and reduce the waiting times for young people that presented with an eating disorder. And lots of documents kind of were put in place to try and establish those waiting times, and across nationally, different teams across the UK were having these specialists training in London, so that we were all kind of working in the same way, to provide specialist outpatient services for young people with eating disorders. And for instance, for our team, we've now got this specialist pathway, and they created jobs for a dietitian, OT and psychologist. Unfortunately, we're still recruiting for a dietitian and an OT. We have had some since our pathway's been established. I think it was established in 2017, or 2017 our pathway was developed, and we have had some dietitians and OT that obviously kind of move on, but yeah, we'll come on to who's in our team later. But yeah, so that's kind of how we became an eating disorder pathway within CAMHs. So this is kind of what it looks like, really, if there were concerns from there was suspected eating disorder from kind of that primary mental health. So thinking of those GP surgeries or possibly schools they're concerned about, there's a potential eating disorder. We always advised, for a young person to go to their GP, ideally at that first point, to have that medical assessment, and to assess, if there's an immediate risk, moderate risk or minimal risk. If it's a minimal risk, then that GP surgery can phone the CAMHs duty line for advice, and they can make that routine referral. If it's a moderate risk, then they could again refer to Solent West CAMHs. And we have done a lot of work with our SPA team. We'll also go on to that a bit later, how CAMHs triage that referral, but we've done a lot of work with our specialist triage team now within CAMHs, about how to assess for an eating disorder. So they're really experienced. So if that GP did phone and need to speak to someone from the triage team, there is usually someone in that SPA team that could support that, with that triage and assessment of an eating disorder. And if they didn't know that, then there's always one of us eating disorder team members around to support that. But if they came to the GP and there was an absolute immediate concern to their physical health, then we would advise that actually they need to speak to our paediatric colleagues at the University Hospital of Southampton. And it may be that they feel that there's a concern about their physical health and they just need to be assessed by the paediatricians. And alongside that, they would still do a referral to CAMHs, and then we would then make an assessment of how quickly they need to be seen by us.
Because generally, I guess, especially in eating disorders, the primary risk generally in the first instance will be physical health concerns because of the impact that it generally has. And so obviously, generally, if anything kind of critical needs to be undertaken for eating disorders, it would always be, I guess in some ways, it's medical monitoring and probably medical stabilisation before anything else.
So the referral to CAMHs for an eating disorder. So if we suspect an eating disorder, then we advise the young person to be seen at the first point as their general practitioner for that physical health assessment. And this is what we require in order to make a judgment of how quickly that they need to be seen. So we need to know their weight and height so we can work out their percentage median BMI. We will tell you how we work out percentage median BMI later. We need to know about the duration and how quickly they've lost weight. We need to know about their physical observations. We need to be asking the GP to be doing their blood pressure, heart rate and blood tests. We need to know about their menstrual history for girls. And we need to know what they're eating, what their diet is at the moment, how regular they're eating and the amount they're eating. And other factors, including their mood, mental state, and suicidal ideation and self-harm, they're often coincide with an eating disorder, and we need to know about those.
And this is what sometimes when we get referrals in, because there's a lot of anxiety about eating disorders, we sometimes don't get a lot of this information. So sometimes a lot of our time is spent having to try and chase for this information, because we use this information, as Laura said, as a means of trying to determine how quickly we need to see somebody. So at this point of time, I think an emergency would normally be someone who's had to be medically admitted. So that would normally be seen within 24 hours. An urgent appointment would be seen by somebody we're quite concerned. Say, for example, they might be eating just like 200 calories per day. They might have lost a lot of weight very, very quickly. They may have like lots of physical symptoms. That might then come under a urgent appointment, which we need to see them within 7 days. And then for other people who obviously there is concern about the impact of the eating disorder, but at that point of time, they're deemed to be as medically stable as they can be. That might come under a routine appointment, which would normally be within 28 days.
And sometimes it may be that the general practitioner may not have that expertise. I mean, they should also follow our marzipan guidelines, which we'll come back to later. But sometimes they may ask us, well, what bloods do we need? And, you know, what OBS do you want us to take? And we're more than happy to liaise with that GP surgery to say, you know, this is what we want, this is what we advise you to check on the bloods, and this is what we want you to do. And we're more than happy to support that. Yeah. And sometimes the triage clinicians, that they may have that referral and they'll immediately say, look, we'll send you the form of what we need you to do before we can, you know, refer to the eating disorder pathway. The eating disorder referral criteria. So significant weight loss, considered an alert or high risk. So if there's been a rapid weight loss of up to 0.5 kilos to 1 kilo per week, it's an alert to us, a high risk. That would be, we would be thinking, right, we need to see this young person as an urgent referral, or potentially needs to be seen within 24 hours at the general hospital for a physical health assessment. If they're really low weight, that's considered urgent. So when we say weight for height, percentage median BMI, 80% or less, again, we'll go through that with you later. That's a concern for us. Considered as urgent if there's low blood pressure, low heart rate, low temperature, they're potentially dehydrated and they're experiencing dizziness, or if they're complaining of chest pains. Again, if they're complaining of chest pains, we would want them to be seen by the paediatric team at the University Southampton Hospital. We've got great links with them, and you know, if we have a referral and we're like, we want this young person to be assessed medically, you know, we're more than happy to have a conversation with our colleagues up there, and they're very supportive. And you know, likewise, if they've got someone that they feel like that's got an eating disorder, they can come back to us as well. So it's really important that we've got that positive relationship and that working relationship with our colleagues at the hospital. So another thing is if there's a total food refusal, that's urgent to us, or excessive purging, self-induced vomiting behaviours, or excessive exercising, that's obviously a concern for us. Another thing, referral criteria, is that preoccupation with food, weight, body image distortion, and body image. That's a referral, you know, part of the criteria. Other comorbid mental health difficulties, like I said earlier. And actually families really struggling to manage the current eating pattern. I mean, they might have a child who's really violent around food and they can't get them to eat anything. Again, that is, you know, something that we would consider as quite urgent. Did you want to mention that?
Okay, yep. So as Laura's just explained about the referral criteria, the kind of exception for that is at this point of time, until we are advised kind of differently, we don't actually, as I said before, we don't actually offer any treatment interventions for young people who suffer from ARFID at this point of time, or any other sensory kind of food difficulties. And we also are not commissioned to offer anything for binge eating disorder either. The other disorder that we're unclear of is purging disorder, because there's not a great evidence base at this point of time for treatments for purging disorder. But hopefully when the next NICE guidelines are updated in relation to eating disorders, they should be included in their clinical recommendations.
So this is what our pathway looks like. So there's been an identification of the eating disorder. So that referral may come into our specialist point of access, which is our SPA team. So that's our triage team. So that may be via telephone, post, email. It could come from GPs, it could come from schools, and it can, you know, we do accept self-referrals as well. So, you know, anyone can make a referral into our SPA team. And like I said, our triage clinician, there is usually someone who is able to triage the specialist eating disorder referrals. If there isn't, they would flag it up to one of the eating disorder members of the team. So they would do a risk assessment and checklist. That may involve phoning the GP for some more information, or speaking to the family to gather a bit more information around a potential eating disorder. Like I said, you know, we often don't get that information that we need, so it could be involved like saying to the parent, right, can you please book an urgent appointment to see a GP, which is provided quite tricky during the COVID pandemic, given that GPs are not necessarily offering that many appointments. But, you know, it's essential that we get those physical observations. Sometimes if, you know, the young person can't get in to have that GP appointment, we will do a one-off here, because we can't make an assessment, we can't assess the urgency without that information.
Yeah, and it can be quite helpful for us then to be able to have eyes on, and we can also access the butterfly clinic at the General Hospital if we need to have some blood, so we can arrange that as well.
So say, you know, standard practice is one of our SPA clinicians will assess that it's an eating disorder and be, you know, and think, yes, this needs to be forwarded onto the eating disorder service. Then one of us clinicians within the eating disorder team will review that referral, and then it's our role to assess the urgency of that referral. So, you know, if it's routine, again, like Anne was saying, we have to see them within 4 weeks. If it's urgent, then it's within a week. An emergency, it will be either they go up to the General Hospital. So we have had them when they've been in the General Hospital and then they've assessed an eating disorder, and because they're in hospital, we then have to go in and assess them quite quickly within that 24 hours. We have had a huge influx of referrals over the last month. We normally have around 6 referrals per month, give or take, you know, but the last month we've had 15. So it's been really challenging to keep to these guidelines of routine, urgent and emergency. We have done our best because we know how essential it is for a young person to be seen within that time, to treat early, but it has been really tricky.
Yeah, and we are actually quite a small team as well, so we cover the best part of Southampton.
Yeah. So this is the healthy weight range. So it's slightly different from an adult, and most of us know that it's the BMI. You know, you can put it into the NHS calculator and they'll tell us whether we're underweight, overweight quite easily. But it is slightly different with a young person. The BMI, it doesn't give a true reflection of a young person because it's not considering their centile charts, and they're still growing. I mean, you know, males can still grow until they're 18, so you know, and particularly when we're seeing, you know, young children, their weight is going to change as they go up that growth. So when young people under the age of 18, the target weight range is based on the young person's gender, height, age and centile, and we use the growth charts to determine where a young person's weight and height and BMI should be for their age. 50th centile is the norm, but we know that, you know, there isn't, that's the norm, but we know that everyone falls in between. 95% percentage median BMI weight for height should be a target, but the reliable indicator for a healthy weight for us is the restoration of menstrual cycles. And we know that the figure of 95, we don't use that concrete. You know, if a young person is menstruating, we've checked that they're ovulating and they're falling at a 90% weight for height. Their thoughts around their cognitions around their eating disorder body image are reduced, then we know actually that's a good weight for them, that's okay. And you know, if you look back at their previous centile charts, they've kind of always hovered around that. So we're not really strict on saying, right, you must get to that 95%. We always provide a weight range as well, so we may give them a target weight range and then give them that +2 kilos, because no one's ever going to stay that same weight. If a BMI drops below 18, it's the same, they say it's the same risk as someone who's got a BMI of 30. So like I said, a healthy weight is reached when there is an absence of symptoms and there's malnutrition, there's no signs of that, and normal growth and puberty. So that is an indicator to us that, you know, they're doing well. So to calculate the percentage median BMI, so it's the percentage of weight for height is used when assessing growth in young people and eating disorders. We luckily don't have to do this calculation. We have a nice little app, our Marzipan app, that will do it for us. But this is the, if you were wanting to work out and you don't have access to the Marzipan app, because we as clinicians have access to that, but to calculate it, you need a gender appropriate centile chart. I've got so used to doing on the app. When I looked at this last night, I was like, I can't remember how to do this. So I had to work it out. I was like 10:30 at night last night and I was trying to work it out, and I did work it out. So you're looking at their current BMI. So, you know, what their current BMI, it may be 15. And then you'd look at a girl's chart, say this is a girl, you'd then look at what their 50th BMI, 50th centile BMI should be. You're then dividing their actual BMI to the 50th centile BMI, and then you times it by 100, and you're then kind of getting this, what we call this percentage. So a low risk to us is an 85% median BMI. Not, you know, we do consider that to be low, but we're not going to be as concerned if we had a 70%, you know, one that was lower than 70%. That's going to be our urgency. That's going to be our ones that we're going to be asking for them to be seen by the paediatricians. And like the concerning and moderate, that's when we're going to be thinking this is, you know, an urgent assessment here.
Okay, so if everyone's still with us, because I'm sure that we've gone through a lot of information so far. So what we aim to talk about next is generally what support do we actually offer once a eating disorder diagnosis has been made. So as I mentioned earlier, because there's no treatment guidelines yet, because they're still work in progress for kind of ARFID, what we're generally focusing on will be anorexia or bulimia generally, and also the kind of atypical forms of that, because if somebody has a diagnosis of atypical anorexia, the treatment for that is the same as anorexia. So just because somebody might fall into the OSFED category, they will still be given the evidence-based treatment. They're treated for the disorder that is the most similar to what they're experiencing, if that makes sense. So generally, am I on the wrong page? Oh, yes. So generally, if there's concerns, normally if someone comes into our service, they'll be offered kind of various interventions and inputs from different members of the team. So we have a specialist consultant child and adolescent psychiatrist, which is Jo Barker. We have various nurses in the team and a healthcare support worker. We have a vacancy for a dietitian, if anybody knows anybody who's interested in working in eating disorders. We've unfortunately had that vacancy for a while. I come from adult eating disorder services, and we had the same problem as well with securing dietitians. So I don't think it's necessarily us. I just think it's maybe like a nation issue.
I think that's also because we can't have a full-time dietitian within the team, and it's usually you can have access to like 1 day a week because of the money, and actually it's really difficult to recruit someone for 1 day. Usually it kind of, they may work at the hospital, but it's just kind of having that special interest, and you need that expertise in working with anorexia and refeeding syndrome.
We have individual psychology, so that might include things like CBT or cognitive behaviour therapy, and that is normally delivered by, we have a clinical psychologist that's part of our treatment pathway. We offer family therapy, and that is usually delivered by one of the family therapists that's working with us. And we also offer a parent support group, which tends to be in the evenings. We also have a vacancy for an occupational therapist. If anybody knows of anyone who's interested in applying for that, that is something else that we have unfortunately not been able to fill that post. But generally, we would just say that in addition to kind of the specialists that we have in our team, that if anyone's ever concerned about any aspect of eating disorder, we would just say in the first instance, just seek help, whether it be from the GP or you can speak to the paediatric teams. We have connections with all those as well. So we are unable to do our work because we have kind of interactions with the paediatric liaison team at the General Hospital. We might have liaisons with the kind of paediatric dietetic teams. And so actually there's a lot of people that actually are involved in working with young people with eating disorders. So generally from a intervention point of view, so say if somebody has been diagnosed with an eating disorder, we, like most NHS services, follow the NICE guidelines, which are recommendations. So the first treatment of choice tends to be what they call family-based treatment, and that is kind of supporting the family to work with that young person, and that is considered to be the first line intervention. If for whatever reason family-based therapy is kind of ineffective or contraindicated, and that might be because the family are not in a position where they're able to offer that support to the child, it might well be the child doesn't live with the family, it might be that there's so much going on within the family, then obviously we will look at other interventions, and that might be what we call CBT for eating disorder or psychotherapy. With a dietitian, we will be able to offer kind of meal planning and refeeding, risk management. We do have access to some meal plans that have been overseen by a dietitian, so we can offer that, but ideally it would be under the kind of definitive advice of a dietitian. Medication is not indicated as the sole treatment for an eating disorder. Sometimes obviously young people might need kind of vitamins or supplements in relation to kind of promote health. Sometimes young people might have an antidepressant because there's mood issues that may be part of the eating disorder or quite separate. But generally, if anyone's offered medication, there should normally be some other form of treatment intervention offered simultaneously. Obviously, the risk in relation to physical health of eating disorders is quite high, so there should be a degree of medical monitoring throughout the treatment just to make sure that that young person is as safe as possible. We offer sometimes extra support to parents if they're really struggling with their child with an eating disorder, whether it be like, I don't know, managing stressful meal times, or in some ways kind of supporting the child to face a fear food. If a child becomes unwell, then obviously we'll consider having a paediatric admission, which involves us having to speak to the paediatric team and getting a medical opinion as to whether or not they feel that this child needs to be admitted. And also as well, if after a period of outpatient treatment that the young person continues to deteriorate, or actually there is no change with outpatient treatment, then obviously we have access to what we call tier 4, or their young person kind of psychiatric beds. Am I still going?
I think you are.
Okay. So as I mentioned to start off with, the kind of evidence base and or the frontline intervention is what we call the MAUDSLEY model of family-based therapy. So this generally involves kind of meeting regularly with the family as a whole unit, and they would normally be expected to have 18 to 20 sessions per year. Those sessions would obviously be reviewed just to see how effective they are and kind of like to discuss any obstacles that may kind of happen as life indicates. It can be completed by all members of the eating disorder team, so not just a family therapist. The emphasis of family-based therapy, I guess it says what it does on the tin, is that it's basically helping a family to support that young person to try and make that family unit as kind of therapeutic in order to kind of get that child to a place of recovery. It's not about blaming the family for the problems. It's just about, I guess in some ways, it's about saying that actually this is the problem, your child is unwell at this point of time, we need to work together in order for this child to kind of improve and get better. So family therapy includes psychoeducation about nutrition and the effects of starvation, because they're quite vast, and actually there's not a lot of evidence or information available as to what the actual effects of starvation are, and they're quite significant. It also looks as to how the families can become more organised around the child with the eating disorder in order to try and find more effective, helpful ways of kind of communicating and working together, and that don't reinforce the eating disorder behaviour. So the model generally over the 18 to 20 sessions, there's normally 4 phases to that. So the first part is kind of getting to know each other. So that will be like the engagement and development of the therapeutic alliance. Once that's been established, then you'll be looking at how the family is supported to kind of manage the eating disorder within the family unit. Then if there's any issues about, I don't know, like systemic issues within the family, they will be explored within that family unit as well, in kind of in a safe therapeutic environment. And equally then there will be discussions probably towards the middle latter part of therapy about ending treatment, because obviously a lot of families and young people can feel quite anxious about treatment ending. So a lot of conversations will be had about that, about like the prospect of ending and what the future plans will be, and looking at things such as like therapy blueprints about warning signs and so on.
I think what's interesting with this model is that particularly when you first see and a young person's just been diagnosed with anorexia, it's almost like, you know, the family have been through so much seeing a young person deteriorate. They almost like want us to take control over the meal plan. They want us to put in the boundaries around meal times. They want us to take over. But as that young person comes out of starvation, they weight restore, they become, you know, they're recovering. That family-based model is handing it back over to that family, so that actually we're not the ones that are taking control anymore. It's about supporting them to, you know, to live a normal life around food and eating. But at that initial phase when they're, you know, they're so poorly and unwell, it's the parents are just like, please just, you know, you just tell us what we need to do. But they become more confident as they go through that cycle, that you know, those phases, that they don't need us anymore. And that's the sign, isn't it, of discharge, when they're managing, they're coping.
And I think as like a nurse within like eating disorders, like I guess one of my passions is trying to destigmatize eating disorders, because a lot of people have this sense of, oh my God, it's an eating disorder, I can't do anything about that. And that isn't just like with families, it's also like with other professionals as well, who may work in different teams. And actually there's a lot of things that people can actually do, and it's not as kind of alien a concept or as frightening as people think it is.
So just talking about our parent support group, this is open to young people who are under the eating disorder pathway.
It's open to
parents, not young people, open to parents under the eating disorder pathway, and it occurs monthly for an hour and a half. It was with a family therapist, but sometimes we kind of interchanged, and it might be two of the clinicians within our team. And again, it allowing that parents to seek support, offer advice, and share experiences with other parents. And it can be so, it can be quite isolating for families who have got a young person with anorexia. And actually it's so nice to kind of speak to another family member, you know, about what they're going through and what they're doing with it. So it's just that, you know, that seeking that support. And we also have different practitioners that will come in and do presentations around the eating disorder. Unfortunately, we don't know if it's because of COVID and us not being able to run a face-to-face group. The amount of people that have been attending has not been poor, and actually this is part of the family-based model treatment, and this is what they need to be doing to help support their young person in their recovery, and also giving them that their space to talk about how hard it is and how exhausting it is and how frustrating it is. So we really do advocate parents using this resource.
So in addition to the family therapy-based model, this is also some of the other kind of interventions that we may offer. So it might be in addition to family-based therapy, it might just be kind of solely on its own. So the evidence base for eating disorders at this point of time, and that's had the most research, is CBT. So generally somebody will be offered CBT with maybe one of the therapists or a psychologist, and that will start working with them on trying to tackle some of the thoughts and behaviours that a young person may have in relation to their eating disorder. We might offer kind of assistance with kind of like making the cognitive factors more flexible. So that would be, I guess, in some ways trying to work on somebody's body image. It might be trying to loosen up someone's core beliefs about their self-worth or kind of general level of happiness. We would work on the behavioural issues which cause significant risk or threat to health, such as reducing down someone's binge eating, restriction, body checking, purging, and so on. Other things we might do is if somebody, and I guess not all people in eating disorders at the point of coming into the service will be that motivated to want to make change, that they might actually feel that there's some benefit of kind of keeping on with their eating disorder. We might offer some motivational kind of therapy or motivational interviewing. Another treatment that's been raised here is called CRT, which is cognitive remediation therapy. It's used more so, I think, with adults, but generally within eating disorder patients, they can hold very, very rigid, fixed views, which sometimes is like trying to, for want of a better phrase, sometimes to try and get through them can feel like banging your head against a brick wall because they're highly held on to beliefs. So sometimes cognitive remediation therapy is used as a tool to try and increase flexibility, to consider like maybe there's a possibility of an alternative explanation, but that's not something that we're using within this service at this point of time because there's specific training involved in that as a treatment.
And I'd like to add that, you know, we don't offer individual psychological support to all our young people with an eating disorder. It's not the first line treatment recognised by the MAUDSLEY or NICE guidelines. So we go through that family-based model first, and obviously if that's not working, we do look to this. But ultimately the young person needs to be eating, they need to be weight restoring, they need to be out of starvation. There is no point giving any kind of individual therapy with someone with a percentage median BMI of 79, because they're not going to be able to cognitively engage in that, because they're going to be, their brain is still starved. So, you know, in order to be able to effectively access individual psychological support, they have to be eating and weight restoring for it to be effective. Otherwise, you're just going to be, unless we're asking that piece of work to be doing motivational work, but we all can kind of do that piece of work within, it doesn't need to be individual psychology to do that motivational work. We as nurses and other practitioners can kind of do that work.
Yeah, and I guess our function, primarily is we have to work with the physical risk that's presented to us. So basically we use more of a behavioural approach, that actually we want the patient to be well, we want them to see them stabilised. So basically we focus on trying to address and kind of remedy the eating disorder behaviours before we can consider any other factors really.
So this is just a little overview of what kind of it looks like within the eating disorder, with the young person family being in the centre of that, and the things that we've kind of talked to you about today and what that looks like in there, and what we can kind of offer. And with the discharge at the end, whether that's going back to our generic CAMHs workers, our core CAMHs teams, it may be that the young person's in a much better place with regards to their eating disorder, but actually still need, you know, support around their mood. And it's not that we ignore the mood, we absolutely work alongside, but sometimes they just need to come out of the eating disorder pathway and have additional support in the different therapies that core CAMHs can offer. It may be that they're discharged and they can go back to their GP and they don't need our old CAMHs support, or it could be we often have young people that are in our service for many years, and like Anne was saying, they could be in our service for 5 years. Because, you know, that's the length of time an eating disorder can be treated. So part of our work is transitioning them to our adult eating disorder service, which is April House. So part of that work is carefully doing that, and we do aim to do that. We start thinking about transition when they're 17. So we often have a question of treating an eating disorder, community or inpatient treatment. I think everyone thinks, you know, a lot of our young people think, or parents think, inpatient treatment must be the best. It's, you know, they're getting 24/7 support, you know, it must be. But actually we know from our experience and from, you know, the evidence of studies that actually the best form of treatment is being an outpatient and being with the family. The family is the best way of a young person can recover, particularly as in an adolescent years. So they should, most people, according to NICE guidelines, need to be managed on an outpatient basis, and inpatient should only be used when there has been a significant deterioration in symptoms, or where outpatient treatment has been unsuccessful. But ideally we try to do at least 6 months. And we know from the evidence that if a young person's had an admission into for treatment for an eating disorder in an inpatient hospital, they will likely have repeated admissions. And, you know, the best thing is to keep them very short and sweet and brief. It's the added complication when they've got a comorbid depression element to it. So sometimes they need to have further admission in, but we do know that actually if you go into inpatient, you are likely to need a further admission.
And I think that that evidence is no different also to adult service eating disorders, that generally admissions are only used as a last resort. Sometimes you feel that, I don't know if anyone's had experience of it, but sometimes the young person can come out of a hospital and actually seem worse for being in there, because they may have kind of copied or picked up on other behaviours that they weren't actually demonstrating in the first instance. They might have actually enjoyed the experience of being in hospital. There's many different factors. So obviously if it's indicated, we request that, but we will try in the first instance to try and help that young person kind of in the security and safety of their own home.
And I've actually personally done a literature review for my master's, and actually I reviewed the literature of, you know, inpatient admission and psychological change, and there wasn't any evidence that psychologically that a young person with anorexia would change following admission. There is no evidence. They're great at weight restoring, but the young person will come back. Not always so weight restoring, but they're better at doing that. But psychologically, yes, you can have as much therapy in hospital, but you bring that young person back into the community, their home life, often psychologically they haven't changed.
Okay, so we're just on the final kind of furlongs now. So
Have I gone?
No, I just skipped over that one.
You've got junior marzipan.
Yeah. So this is what we use as a kind of like physical risk assessment tool in kind of looking as to how quickly we need to prioritise young people. So marzipan is basically the acronym for Management of Really Sick Patients with Anorexia Nervosa. And there's a junior marzipan, and there's also like an adult marzipan as well. And that came about with the amount of concern that was being raised at the time about the amount of people with eating disorders going into medical beds and the kind of medical management of them when they were outside of an eating disorder service. And so basically there was like hundreds, well, maybe not hundreds, but there was tens of professionals that were involved of all different kind of specialisms and expertise that kind of got together in order to draft these kind of recommendations for medical monitoring. So the key recommendations from the marzipan guidelines is that the risk parameters need to be adjusted for age and gender, including BMI, and that was felt that younger people are more at risk of eating disorder kind of physical effects than adults are, because obviously they're not fully developed. Their body might not be used to kind of having such low weight. Parents and carers play a central role in care and decision making until the patient is 18. There's obviously something about Gillick competence in there as well, which will be considered. Primary care services must refer as early as possible to specialist services. And as Laura said before, that's the evidence base that kind of early intervention is kind of the key in order for kind of successful recovery. And a lead consultant paediatrician and a lead consultant psychiatrist should be identified to coordinate care for the junior marzipan patients. So that would normally be our consultant here, potentially Joe Barker, and that will be then the nominated paediatrician at the general hospital as well.
We have got paediatricians that have got specialist interests in eating disorders, so they tend to kind of be the ones that would oversee their care.
So the marzipan identifies what they consider to be high risk factors in eating disorders, and so thereby that's very low weight. As already mentioned, there's a degree of rapid weight loss as well, normally 1 kilo over 2 consecutive weeks. Generally, somebody would have a very low dietary intake, so anywhere between 400 to 600 calories a day. But recently, we've assessed somebody who was eating 200 calories a day, and that was over a significant period of time. Equally, if somebody is vomiting or misusing laxatives, that increases the kind of physical harm risk too. Previous history of refeeding syndrome, I'll speak about that in a second. And generally, the lower the weight, the kind of more neutropenic a young person may be. And that generally means that they've got low white cell counts, and white cells are responsible for fighting infection. So the lower that they are, the more likely that child is at risk of developing an infection, which obviously is another risk factor to kind of life.
Just to also add that, it's not on these slides, is actually eating disorders have the highest mortality rate of any mental health illness. So that's why it's essential that we see these young people and get them before it gets chronic.
So refeeding syndrome, I'm not sure how much people are aware of this, but this is kind of particularly serious if somebody is going through a period of refeeding. So say, for example, if a young person has had a long period of starvation, eating between 400 to 600 calories or less per day over a prolonged period of time, and has lost a lot of weight, the first week of their refeeding needs to be done with kind of expert supervision, really. I won't go into all the details here because I'm a nurse, not a medic. But generally, if somebody is refeeding, there's lots of physical changes that take place within the body. And actually at that time, it's a risk. It can be a risk to life. So sometimes when we have young people come in, them and their parents might start to panic at the potential that they might have to go into a medical bed. And there's a real risk that people will just start to eat. And it sounds a bit ironic, but actually we have to kind of advise people that please do not eat off plan. The natural tendency might be to eat more in order to try and get the weight up, in order to try and keep the young person at home. But by doing that, they're actually placing the child at a greater risk. So it sounds a bit ironic, but we would say to people, yeah, we do want you to eat more, but we want you to eat more gradually, which sometimes can be interpreted a little bit unusually, but that's just basically just to try and keep a young person as safe as we can until we know that their body can tolerate an increase in calories.
And you know, we can manage that in the community.
Yep.
We are quite skilled at managing refeeding syndrome, so ideally we would do that in the community. They have to have a lot of bloods, and we have to do a lot of blood forms and increasing meal plans, but we can do it. However, if a young person, like we said earlier, is below 70% weight for height, usually we'd be asking for our paediatric colleagues to assess them. Usually the bloods will show something that's not right, and usually they'll end up being in hospital to be refed and then discharged. So, you know, we very much work alongside our colleagues to make that decision about whether we could do it in the community, but ordinarily we are very skilled at doing it in the community. And this is just some resources that you may find helpful in terms of reading through that you might find. So B is a good one, and Freed is quite good in terms of why we need to treat early.
Yeah.
And now we come on to questions.
So thank you very much for listening to us waffle on for an hour and 5 minutes. Oh, hour and 10 minutes, I think we did. I feel wiped out now. So.
I bet you do. Thank you. Right, if we stop sharing a screen for a minute so I can, I'm just trying to figure out how to do that.
I can do that. I can.
Yeah, is that okay? There we go. That's great. Thank you. Thank you. That was so fascinating. I've learned loads. My brain is just sort of whirring and taking it all in. It's really useful, and so useful to have it all sort of written down on the PowerPoint. So thank you for your sort of time and effort. We have loads of questions. Well, thank you.
And our student.
I did nothing, so.
We have loads of questions, but I'm really aware that time for a lot of our families is, we've sort of gone over our usual allotted hour, and so some people might want to leave. I don't know whether you would prefer me to ask questions now, or I can email them over. We've got quite a few that have come up on the chat, and I can also see, you know, if anyone here right now has got any questions they'd like to ask.
We're here till 12 because we were from half 10 till half 10, so we've got 20 minutes if you want to ask.
Okay, all right, well, let's do that then. Let me go with, has anyone that's currently here and sort of if got any questions to ask? If I hear nothing, I'll just plow on with mine and just chip in if you do. Okay, let me find the questions that I have. So we've got a few on the chat option. First of all, so I'm just literally going to read them out to you. So a child or young person with autism wouldn't be diagnosed with ARFID then, as it's due to sensory reasons with the autism. Is that right?
No, they can be diagnosed with ARFID as well.
Okay, brilliant. And somebody else has asked, what would be the benefit of getting a diagnosis? I'm thinking of ARFID if you don't get any support for it.
Well, there is support available. It's just not kind of specified by CAMHs. So they might have like community paediatrics involved. They might have alternative services involved. And as we said earlier, there is an ongoing discussion at this point of time about treatment interventions for ARFID. So I think there are support networks around that can be accessed. They're just not defined at this point of time.
I know that with Dr. Barker and our service manager Chantel, they've been having meetings with commissioners and other, you know, services, paediatricians and other services within the city, and one of the things that they're doing at the moment is collating how many referrals we're getting through, so that they can kind of think, you know, where is that going to, you know, where is that treatment going to fit, because we can't assess all young people with ARFID.
Yeah, no,
we just wouldn't, you know, there's probably a lot of young people out there that may fit that criteria. So it may be that not just CAMHs, other services can also assess that.
Okay, that's really useful, thank you. Another one says that we've met all the ARFID criteria and have only been told we can have access to a dietitian or school nursing team to monitor weight despite not eating for weeks, losing weight, dizzy, etc. So what are the contact details to self-refer? Is that just like we do any self-referral to CAMHs?
Yeah.
Okay, so we've got the referral forms within our group so that I can easily pass those on. Sorry, I answered my own question.
As well, equally, we might be limited as well as to what we offer as well, because at this point of time, who treats ARFID? And I know that obviously it's not helpful for parents who are obviously concerned about their child, but it's a grey area as to who actually is commissioned to treat ARFID at this point of time.
Okay, yeah. Yes, that's what I've heard as well. All right, thank you. Okay, so if I go to some of the questions that I received before the meeting from parents that couldn't make it. So the first question is, what support does CAMHs offer for avoidance food restrictive eating disorders? Well, I guess we've just discussed that one again, and covered that one. So another sort of comment, as much of a question, was why do they put children on the harsh anorexia program, even in hospital, when they do not have dysmorphia? Why do they not automatically screen for autism and then look at supporting associated eating problems? This person said, a large number of girls my daughter was in hospital with did have anorexia, but later got diagnosed with autism. Why are they not screened automatically and then treatment could be adapted so they respond better and avoid hospital admission?
It depends. You can have a diagnosis of autism and have a diagnosis of anorexia as well. So I guess in relation to anyone being in hospital, I guess it would be the medical risk that would be the first port of concern. And I guess in the first instance, that would always be treated.
Yeah, okay.
Yeah, so
yeah,
it'd be because of ARFID or anorexia. If a child is medically unstable, that is what needs to be treated first.
And also, I guess autism isn't always easy. It's not as quick to diagnose as maybe anorexia. We can endorse referrals, but that's not going to be our priority in the eating disorder. It's going to be, like Anne's saying, it's the medical. So it may be that, yes, we've got suspicions, we could possibly autism. We can kind of consider that when we're treating them, to think, okay, can we adapt our ways of working with this young person if we think they're presenting with autism? But to get that full diagnosis, they may have to go on a waiting list from the autism service, or if we can get one of our colleagues working alongside us to do an endorsement if there's enough evidence to do that.
Okay, thank you. Okay, next one says, after 12 years of fussy eating, when does it become an eating disorder enough to be recognised by a GP?
When, I guess according to the guidelines, will be when there is a impact on the overall physical well-being. So say, for example, if there's developmental difficulties or someone fails to kind of reach the kind of height weight expectations, if there's nutritional deficiencies, if there's a lot of kind of distress at home. So any of those will be kind of criteria for the GP to be maybe looking into like an ARFID diagnosis.
Okay, brilliant, thank you. And I think this probably covers the same sort of thing. It says, I'm interested to know if any help is available to expand the typical autistic BINGE diet. I think a lot of us can appreciate that one.
I know the MAUDSLEY at this point of time are obviously Rachel Bryant-Waugh does a lot of work and research into ARFID, and she's obviously trying to raise the profile of the ARFID diagnosis. There are a couple of books that are available, I mean, such as on ARFID, and I think there's a book on CBT as well, and I think a lot of it is about, you know, exposure. So in some ways that kind of graded hierarchy to introducing different foods over periods of time.
Okay, thank you. Right, we're nearly there, a couple more. So food avoidance and restrictive diet is a massive problem for us. Been seen by a dietitian at the hospital, but we were offered no advice or support for this. Is there any help available? And I guess we're coming back to that, that same thing. I think it's a big issue with what, you know, many of our families is the ARFID type issues. maybe we could at some point have a session just on ARFID and sort of looking at, you know, practical strategies of things we can do might be really helpful.
Yeah, because as a service, we had a training session on ARFID, but it wasn't about how to treat it. It was more about the diagnostic features of ARFID. So we might be more informed about the ARFID diagnosis, but equally it sounds like what people are wanting to know is obviously how can you help your child?
Yeah, I think that's sort of the tone of every question I've got really is around that side of things.
We did assess a young person who presented with ARFID a couple of days ago, and they were actually, you know, wanting some support. The parent had already kind of put in some support around behaviour management. And it was one of our clinical psychologists who kind of assessed them and actually was able to kind of support that behaviour management, but to maybe kind of adapt it. And, you know, that we're not going to be able to continue treating, but we will review that young person and those strategies. So, you know, that is something that we could consider, maybe having our clinical psychologists, you know, speak about ARFID and possible behavioural interventions that may be appropriate.
That sounds really useful, actually. Yeah, that would be great. We definitely welcome that. I've got a question from Lucy there. On the other end of the scale, she says, I'm not sure what the diagnosis is, but how would I find out about my child who feels constantly hungry and constantly eats? Try to monitor his diet, but is significantly overweight, which is monitored due to meds he takes, but no one seems concerned about his weight issues.
That's quite tricky. I would say probably GP, or in some ways, if the dietitian that the young person is working with should be raising concerns about that.
Okay.
Yeah,
and then what's the sort of pathway if you've got a child that's sort of eating constantly, you know, and always hungry? Is there something down the eating disorders pathway for that, or is that just sort of...
It would only be if it was like binge eating, but as we said before, that isn't something we're commissioned on, and binge eating is normally kind of discrete periods of eating large amounts of food, so it wouldn't be like constantly eating. I mean, I know there's the disorder, is it Prader-Willis disorder, where there's kind of that insatiable kind of appetite, and it's whether or not it's about speaking with the GP. But equally, I think if it's because of the medications that are being taken, then actually that would need to be a conversation with the actual prescriber. Yeah.
Okay. All right. Well, thank you. I'll just give it a sec to see if we've got any other questions or if anyone else wants to ask. It's been so useful. I've learned so much. So thank you ever so much for your time. Yeah, and if we can ever have you back again to do any more, we'd really love that, and certainly something on ARFID would be, I think, really useful for our families. But thank you very, very much for your time this morning. We really appreciate it.
Thank you very much.
It's nice to see you.
Thank you.
Thank you. Bye bye.